Morning, everybody. Welcome to Grand Rounds. Please join me today in welcoming our Grand Round speaker for this morning, Dr. Ammar Nasir. He was born in Lahore, the capital and largest city of the Punjab province of Pakistan, but was raised in Edison, New Jersey. He earned his bachelor's degree in applied kinesiology and exercise science from Rutgers University, followed by his medical degree from Rowan University. Following his upcoming graduation, he plans to pursue a career as a skilled nursing facility consultant while also engaging in part-time acute inpatient rehab work. We're honored to have him with us today. Please welcome Dr. Ammar Nasir.
Good morning, everyone. Thanks for being here today. As Trevor mentioned, for those of you who haven't worked with me before, my name is Ammar Nasir. I'm a fourth-year resident, and I'll be going into a SNF consultant position afterwards. Whenever I kind of mention this, I often see looks of confusion. Many medical specialties aren't really sure what PM&R does, and similarly, I think many PM&R doctors don't really understand what a SNF consultant is. There's limited understanding of what we do, yet this field is rapidly growing, and many PM&R graduates across the country are choosing this path. I've even heard stories of a lot of people abandoning their fellowship matches to join companies that are doing SNF work. Throughout residency, I wasn't entirely sure what working in a SNF entailed either, but I knew colleagues who were thriving in the space. It wasn't until I worked with Dr. Sway that I fully grasped the impact that PM&R can have in SNF. Currently, we don't have a dedicated subacute rehab rotation, but given the expanding role of physiatrists in SNF, I anticipate this will change in the future. I viewed this presentation as kind of an opportunity to learn about SNF, how PM&R fits into the setting, and how big organizations like Madrina, US Physiatry, and even now VCU Health are marketing themselves to SNFs and SNF companies in the area. So by the end of this presentation, you should have a better understanding of how to introduce subacute care settings, understand the factors that influence discharge of SNF versus IRF, describe the current research on challenges skilled nursing facilities face, explore the role of physiatrists in SNF settings, understand current landscape of SNF setting, and identify the benefits and limitations of a physiatrist's involvement in subacute rehab, understand what PDPM is and how it applies to PM&R. Why this topic matters, because this discussion is necessary because there's a clear gap in both research and clinical care regarding physiatrists' involvement in SNF. While studies on this topic remain limited, the number of physiatrists working in SNF is increasing dramatically. And given the national push to reduce healthcare costs and the growing reliance on SNF for post-acute care, physiatrists should consider how we can integrate into this setting to improve patient outcomes. So what is subacute rehab? Subacute rehab typically refers to the rehab programs offered in SNFs, but the term doesn't have a standardized definition. It's not explicitly defined in Medicare regulations or any other regulatory standards. It often does encompass things like IRFs, LTACs, SNFs, and home health. It specifies that SNF provides long-term rehab for patients who are not candidates for IRF care due to lower acuity or limited therapy tolerance. Subacute rehab differs from inpatient rehab facilities in key ways. Fewer hours of therapy, less stringent admission criteria, lower requirements for medical oversight and nursing care. And a large majority of these SNF facilities have dual certification as both SNFs and nursing homes. In contrast to SNFs, nursing homes, by definition, typically provide less intensive long-term stays that extend beyond what Medicare covers. That's going to be outside of today's scope of discussion, but it's important to know that typically they do have a bunch of nursing home beds as well. So this chart kind of shows that SNF typically treats lower acuity, offers 1 to 2 hours of therapy per day, have weekly or even monthly physician visits, and feature longer stays with significantly higher readmission rates, about 23%. In contrast, IRFs require a patient to tolerate at least 3 hours of therapy daily have daily physician oversight, shorter length of stays, typically 12 to 16 days, and lower admission rates, 10%. Obviously, this will vary from IPR to IPR. This comparison underscores why intensive oversight in IRFs may lead to a better outcome in certain cases. So the factors that I kind of mentioned collectively suggest that SNFs, while crucial for long-term rehab, may not always provide the intensity needed for optimal recovery. In a 2022 study published in the PM&R journal, Dr. Chan conducted a retrospective analysis of about 130,000 acute ischemic stroke patients to identify factors influencing discharge destinations to either inpatient rehab facilities or SNFs. Comparative data in the study showed that IRFs yield faster functional gains due to the higher therapy intensity and daily oversight. IRF patients regain mobility 40% faster with significantly better improvement in the Barthel index. It's 35% in an IRF, 20% in a SNF. I want to emphasize that this study also found that patients discharged as SNFs were older, they had longer hospital stays, more comorbidities, and higher ranking scores compared to those in IRFs. What is a ranking score? It's modified ranking scales often used to measure the degree of disability or dependence in a daily activity of patients who have suffered a stroke or other neurologic conditions. So why does this matter? Studies have consistently shown that better patient outcomes happen in IRFs compared to SNFs, even when adjusting for multiple variables. But despite these findings, SNFs still remains the dominant post-acute care setting. And we'll go into why. So currently there's about 15,000 SNFs in the US. That serves close to 1.3 to 2 million patients annually. That comprises about 4% of all Medicare users. Over 90% of SNFs function as nursing homes. So the trends in the SNF utilization, as of 2025, SNFs account for about 60% of post-institutional acute care in the US. IRFs are about 25%, LTACs are about 15%. Total healthcare costs associated with SNFs were 3 times higher than those incurred by inpatient rehab facilities. That basically shows that there's a lot more money flowing to SNFs. And then this trend is unlikely to reverse given the focus on reducing healthcare costs. So just to highlight this, I took a look in Virginia. Virginia itself has 280 to about 300 SNFs, but there's only about 16 to 20 IRFs in all of Virginia. In Richmond itself, there's 43 SNFs, but only 3 to 5 IRFs. To help understand this, we need to break down and evaluate the fiscal cost of these post-acute care settings. So what are the cost differences and financial incentives that kind of play into this? SNF's average cost is about $550 per day, while an IRF costs about $1,300 per day. Over a typical 30-day stay, a SNF costs around $16,000 and $16,500. Sorry about that. I can't read sometimes. Whereas 16 days IRF stay totals about $20,800. Although IRFs are more expensive on a per day basis, they achieve faster recovery, potentially reduce long-term healthcare costs by lowering the readmission rate and decreasing patient dependency. However, Medicare and private insurance favor lower upfront costs, making SNF a more financially viable option, despite the potential for better long-term outcomes in IRFs. SNF provide less intensive therapy, require fewer specialized staff, and serve a broader range of patients, which keeps the operational costs low. And to kind of highlight this, if you take the total cost of 20 patients over a 14-day period in IRF, that'll only cost you $364,000, but the same amount of patients in a SNF would cost you about half of that. So why are there more SNFs than IRFs? There's more to it than just the money. Big thing is accessibility, admission criteria, and reimbursement models. This disparity significantly impacts where patients go for post-acute care. Let's talk about the other factors other than just the financial incentives and lower costs. So therapy intensity and admission criteria. IRFs provide about 3 hours of intensive therapy per day, along with daily physician oversight. SNFs do about 30 to 90 minutes of therapy per day and require physician oversight only every 30 to 60 days. Because of these requirements, not all patients qualify for IRF level rehab. Many frail or lower functioning patients are better suited for SNFs, making them the default post-acute care option for a larger patient population. Hospital discharge pressures and bed availability. Hospitals prioritize rapid bed turnover, leading to more referrals to SNFs, which are more widely available than IRFs. IRFs have stricter admission criteria and fewer beds, limiting their ability to accept all post-acute care patients. SNFs with broader admission criteria can accept a wider range of patients, including those only needing low to moderate rehab or extended nursing care. The higher availability and easier admission process makes SNF the more common discharge destination for post-acute care. And also some areas simply don't have an IRF nearby, and a lot of family members will opt to keep their loved ones closer to home and just send them to a SNF. And then Medicare payment models, which is a huge influence, favor SNFs. Medicare policies contribute to the higher number of SNFs as well. IRFs operate under a fixed payment model. It's called the IRF prospective payment system, meaning they take on financial risk if a patient requires more resources than expected. SNFs use the patient-driven payment model, PDPM, which bases reimbursement on a patient's nursing complexity rather than therapy intensity. This allows SNFs to maximize revenue without providing high-cost therapy services. Additionally, Medicare's 3-day rule makes SNF admission criteria easier for hospital discharge patients, reinforcing their higher utilization. So, in conclusion, why do SNFs outnumber IRFs right now? They're cheaper, more accessible, serve a broader patient population, and hospitals and insurers prioritize cost effectiveness and availability, which leads to more discharge of SNFs over IRFs, even when IRFs may provide better functional outcomes for certain conditions. The combination of lower costs, looser admission criteria, and the favorable policies ensure that currently that will remain a more common post-acute care option. Today, we'll focus on Medicare as it is the predominant payer for most subacute SNF visits. For a patient to be covered by Medicare, they must have Medicare Part A. They must have a qualifying hospital stay, which includes at least 3 midnights in the hospital. They must have a need for skilled therapies, typically provided 6 days out of SNF. They must have a hospital-related medical condition. Some of the most common diagnoses seen in SNFs are post-sepsis, minor joint replacements, even though now some of those are just being sent home, heart failure, UTIs. So how are SNFs paid? Medicare covers up to about 100 days in a SNF per benefit period. The first 20 days are fully covered, but after day 21, the patient has to pay a daily copay of about $209 in 2025. After 100 days, Medicare stops paying, but a new benefit period can restart if the patient stays out of the hospital and SNF for 60 days and meets the 3-day hospital rule. Medicare reimburses SNFs and IRFs differently. SNFs receive daily payments, or often known as premium, meaning longer stays generate more revenue, but IRFs are paid per discharge, meaning they focus on shorter intensive rehab stays. And in 2019, the Medicare switched SNFs from the RUG-4 model to the PDPM system, and which we'll talk about a little later. So quickly reviewing some of the big parts of Medicare. Part A covers inpatient hospital care, skilled nursing facilities, hospice care, and some home health for beneficiaries over 65 and those with recognized disabilities. Because SNF payments are so intricately tied to Medicare, it's important to understand the regulating bodies that oversee changes to the payment policies. The biggest body is MedPAC, Medicare Payment Advisory Committee. It's a nonpartisan legislative branch that provides Congress with policy analysis for Medicare. So twice per year, March and June, MedPAC, they submit a report to Congress that talks about Medicare utilization, access to care, quality of care, and other related issues. One chapter of these reports specifically addresses SNF services. Although these recommendations don't automatically affect the national budget or become law, they're important to keep an eye on. So unlike IRFs, which are reimbursed on a tiered per discharge basis, SNFs are done per diem every day. In October 2019, a new financial challenge arose when CMS and MedPAC and the Department of Health and Human Services agreed to initiate a new reimbursement system. This change shifted from the historic RUG, or the Resource Utilization Group 4, to the patient-driven payment model. So under RUG 4, everything was really all about typically volume-driven case mix group influenced by the minutes of therapy provided. This led to an overemphasis of therapy minutes, leading to overtreatment, inefficient resource uses, and the overemphasis on therapy minutes kind of incentivized SNFs to provide excessive therapy because reimbursement was, again, largely based on the total number of therapy minutes rather than patient needs. This led to potential overtreatment and inefficient resource use. So the RUG-4 is kind of a one-size-fits-all classification. The patients used to be grouped on therapy use rather than their complexity, meaning that patients who often had higher medical needs but lower therapy were often underfunded. There was a potential for gaming the system. Since payment was tied primarily to therapy volume, some SNFs manipulated therapy delivery to qualify patients for higher paying RUG categories, sometimes providing unnecessary or inappropriate therapy. PDPM was designed to shift the focus from therapy volume to patient complexity, ensuring reimbursement reflects medical conditions, nursing needs, and functional impairments, rather than just therapy minutes. It promotes more individualized patient care, prevents overuse of therapy services, and encourages more accurate reimbursement based on patient needs rather than arbitrary therapy thresholds. SNFs now use ICD-10 codes to establish patient acuity and comorbidities, which more appropriately drive reimbursement based on patient complexity. So let's talk about what PDPM is, patient-driven payment model. There's 5 main case mix components: physical therapy, occupational therapy, speech, nursing needs, and what we can really help with as well, the non-therapy ancillary needs, the NTA. So basically, this classifies patients into case mix groups based on clinical complexity rather than therapy minutes. We use accurate classification tools like the FIM, Barthel Index, AMPAC, which are essential for proper reimbursement. Case mix groups are important because they ensure that patients are categorized appropriately, and that directly correlates to the reimbursement amount they're paid daily. The NTA component really captures patient acuity and medical complexity. It includes expensive drug costs, other factors associated with medically complex patients. And essentially, each of these components gets a per diem rate applied. And when tallied totally, they give the overall per diem rate for the patient. The key takeaway is that while the previous reimbursement model primarily rewarded therapy minutes, the new model adjusts for higher costs and complexity of more medically complex patients. And as you'll see on your rotation with Dr. Swery, there are often now very complicated patients in SNF, ranging from LVADs, ESRDs, and even some spinal cords. So what does PDPM have to do with us? PM&R plays a very crucial role in optimizing PDPM reimbursement through precise patient classification and documentation. By utilizing validated assessment tools like FIM, Barthel Index, podiatrists ensure that functional impairments and medical complexities are objectively and properly recorded, leading to higher case mix reimbursement. This prevents undercoding and loss of revenue and ensures SNFs receive the appropriate financial support for the level of care provided. And moreover, PM&R physicians improve IDT documentation, ensure that nursing, therapy, and medical records align with the PDPM criteria, And it's particularly important for capturing NTA or non-therapy ancillary comorbidities, functional dependencies, and cognitive impairments, which all significantly impact reimbursement rates. From a financial standpoint, all this helps SNFs get justified payments without relying on those excessive therapy minutes. And during this next slide, if you haven't been paying attention, this would be next 5 to 7 slides really are going to hopefully highlight how and show you evidence of what we do. So these are 5 things if anyone ever asks you like what you do in a SNF and how this is going to help them in marketing yourself. And this is kind of a lot of what these big companies tell these facilities. Well, number 1 is accurate ICD-10 coding. We document comorbidities, functional impairments, cognitive deficits, which results in higher case mix scores under PDPM. We do comprehensive functional assessments. We can document FIMS, Barthel Index, and AMPAC. Physiatrists can quantify disability levels, justify higher reimbursement. We could management of medically complex patients. We make sure patients with neuro injuries, strokes, polytrauma are classified correctly. We optimize NTA payment. We capture the high cost medical needs, ventilators, wound care, any resulting infections, and that increases the NTA scoring. We reduce rehospitalizations. We address pain management. And shockingly, some SNFs will even send people out to get simple like pain management and joint injections to the ED. Mobility issues, chronic conditions, and we prevent unnecessary readmissions. As physicians in a facility in which patients are only seen in 30 days, there's a lot of high risk, and then we can provide that added medical oversight and help reduce preventable complications. So next are examples that have actually like looked into the 2025 reimbursements. So this is how the direct impact we have. So we ensure the functional impairments are accurately captured on the MDS section, which is section GG, which is functional abilities and goals. For example, for those of us who have been in the SNF, when you document multi-muscle weakness, sarcopenia, gait instability, or falls, that justifies a lower mobility self-care score. And that lower functional score increases the patient's case mix index for PT and OT specifically. For example, without PM&R, the MDS GG score showed moderate assistance needed, and the PT/OT reimbursement was $196 per day. With PM&R involvement, when we documented deconditioning, balance issues, and neuromuscular weakness, they were classified into a higher group, and their PT/OT per diem went up to $224.37 a day. So we essentially ensure that PT and OT evals are capturing true functional deficits, highlighting any neuromuscular impairment that impacts mobility, post-stroke, neuropathy, deconditioning. And then we link diagnoses like sarcopenia, myopathy, any Parkinson, spinal stenosis to functional limitations the patient is having in therapy. For example, how do we help with the SLP component? PM&R can diagnose and document mild cognitive deficits, post-stroke deficits, dysphagia. If SLP is needed and is not captured, the facility loses that component of SLP reimbursement. Without PM&R involvement, mild cognitive dysfunction was not coded. The speech reimbursement was $54 a day. With PM&R involvement, we made sure to document cognitive issues and swallowing impairments that bumped their per diem up to $68 a day. We can order things like cognitive screenings like the MoCA and document its results. We can make sure dysphagia is assessed by the speech therapist if suspected. And then we could diagnose things like post-stroke aphasia, dysphagia, Parkinson's related speech issues. And then moving on to the NTA component, PM&R could diagnose overlooked conditions like myopathy, severe neuropathy, cachexia, chronic palm debility, which adds NTA points. And each NTA point increases per diem reimbursement, especially in those first 3 days. Without PM&R involvement, they only coded diabetes, which is $385 a day, After we saw them, we added severe neuropathy, adds 2 points. We added chronic palm debil, which would add 4 points, and that would bring them up to about $549 a day. So how do we do this? We can review the patient's history for high-value comorbidities, cachexia, neuropathy, any chronic CHF or respiratory failure. We make sure metabolic and neuromuscular disorders are captured, severe osteoarthritis, post-stroke spasticity. How do we help with their nursing component? So PM&R can document neurodegenerative diseases, debility, and muscle weakness to justify higher nursing scores. And nursing reimbursement is based on the acuity. So PM&R input on ADLs and nursing intervention really matters. Without PM&R, someone was coded as low complexity. The nursing per diem was about $229 a day. With PM&R reimbursement, when we documented neurogenic bladder, spasticity, severe contractures, or pain management, bumps them up to 269. So we got to make sure we're documenting higher nursing complexity, things like pain management, complex wound care, and that helps justify higher nursing complexity scores. We could also capture neurologic disorders affecting ADLs like post-stroke deficits, and we can help coordinate nursing and rehab services to justify increased complexity. So kind of final takeaways of the few things that I mentioned. What we do is we maximize functional scoring by ensuring PTOT levels reflect real limitations, increasing therapy reimbursement. We capture high impact comorbidities, adding correct diagnoses, myopathy, cachexia, any palm debil. We enhance the speech reimbursement. If a patient has cognitive deficits, dysphagia, or post-stroke speech impairments, that qualifies them for higher SLP rates. Same thing when we increase the nursing complexity ratings. If PM&R manages spasticity, pain, contractures, complex neuro cases, that increases their scores. And we support early documentation for the first 3 days, since NTA payments are highest in the first 3 days. Early PM&R intervention maximizes their reimbursement. So that's about a total of like increase $122 per patient per day. So for about a 20-day SNF period, that results in an additional 2.4K in reimbursement per patient. And then if you were to add those first 3 days reimbursement, that's an increased $500. So this is a real example from IRC when they did a presentation. So in the above scenario, without PM&R, the hospital discharge diagnosis alone, the SNF was getting $544. But after PM&R saw them in this patient, that bumped them up to a total of $630 per day. So if you kind of like alone per patient, when we talk, it just seems like we're only going up 30, 40, 50 bucks sometimes. But if you take a facility that's getting paid, using that previous example, a rate of $554 for 14 patients for 20 days in a year, that results in about $1.8 million. But when you add PM&R with that same patient caseload, you went up to $2.11 million. So that's just increased reimbursement with one PM&R diagnosis. Remember that SNF stays are typically longer than 14 days, and they're not dependent on turnover either. So what's the opportunity cost of not having PM&R in a SNF facility? For a 20-patient facility, that you're losing out on $255K. For a 50-patient facility, $638K. And for those of you that know, those are relatively small facilities, like 100, 200 bed facilities with rehab beds. You're losing out on a significant amount of money by just not having PM&R. And that's all the explicit benefit that we are providing. This is not even covering the medical oversight we provide when we're there. Now that we have a better understanding of Medicare and SNF payments, let's transition to some of the challenges that SNFs face when that often lead to adverse events and hospital readmissions. And that's something that's implicit that we can kind of provide by being there. So SNFs have tremendous variability in their staffing, cost efficiency, and patient outcomes. This variability directly impacts quality of care, as some facilities provide more nursing coverage than others. There's 3 main requirements for a SNF. The attending physician needs to see the patient every 30 days for the first 60 days. After that, the requirement becomes even more lenient. In most cases, physician extenders, NPs, or PAs see the patient about 1 to 2 times a week, but this really depends on the acuity of the patient. Only one RN is required to be at the facility for 24 hours every day, and that's actually an updated requirement for 2025. SNFs must provide at least 3.48 hours per resident of direct nursing care. That breakdown could be 0.55 hours from RNs, 2.45 hours from nurse aides, CNAs, 0.48 hours from any combination RNs, LPNs, or CNAs. There's no mandated nurse to patient ratio. Unlike hospitals, SNFs are not required to maintain a specific nurse to patient balance. Some facilities may assign to one nurse to a dozen of residents. CNAs provide most of the direct care. While RNs do oversee medical issues, the majority of hands-on care is done by CNAs, who are often stretched very thin. Some high-quality facilities may exceed these staffing levels, while others may barely meet the minimums, leading to inconsistent patient care. So research has consistently demonstrated a strong link between nursing staff levels, particularly RN coverage, and patient outcomes. So the last study they did in a facility like this was in 2001. It was a CMS study, and it showed that a higher nursing staffing level showed fewer hospitalizations, lower mortality rate, and reduced pressure ulcers. It established that those kind of minimums of 4.1 nursing hours per day to prevent serious harm, broken down into 0.7 hours from RNs, 0.55 hours from LPNs, and 2.8 hours from CNAs. Further research, including a 2016 analysis published in the Health Affairs, reinforced that RN staffing directly correlated with fewer hospital readmissions and improved functional outcomes in SNF residents. In 2020, a study in the Journal of American Medical Directors Association analyzed over 600 SNFs and concluded that facilities meeting or exceeding that 4.55 hours per day ratio of nursing had lower rates of infection, falls, and medication errors that supported the prior expert recommendations. And then despite these findings, there's no federally mandated staffing minimum, and that's how it's been for decades. And as I talked about, just in 2025, they implemented a new staffing requirement, now mandating 3.48 hours, 0.55 hours from nursing, 2.45 hours from nursing aides, and a new 24/7 RN presence as compared to previously they only had to be there for 8 hours. While these new standards aim to enhance patient safety, they still fall short of prior expert recommendations, and compliance deadlines vary. Urban SNFs are required to meet the new standards by May 2026. Rural facilities have until May 2027 to meet those new requirements. And SNFs have actually kind of tried pushing back on this, but despite that, federal courts have upheld the new staffing requirements. So this all really highlights the need for medical oversight. Having a licensed medical physician who's not only a rehab specialist, but someone who has a strong general medicine background can provide an additional safety net and resource for nursing staff. It's kind of like us being on call here at SAI. The facility is not necessarily making money off that, but we provide an implicit benefit. We're there when someone has an issue. We're able to respond to pages. So just because like you're not. And again, one thing that I probably didn't say earlier is that we come at no cost to the facility. The facility does not have to pay any money to have a physiatrist on board. We bill the patient directly. So one thing that can kind of help is the 5-star rating on this website called Care Compare. Beyond staffing, SNF performance is measured through key quality indicators such as hospital readmissions, facility-acquired infections, fall rates, All of this contribute to their 5-star quality rating. It's critical factor in preferred provider status within healthcare networks. Research shows that higher staffing levels improves patient outcomes, yet many facilities still struggle with recruitment and retention due to workforce shortages and financial constraints. And again, if we are adding like that extra $500,000 per year, we can alleviate some of those financial constraints. Patients and families can evaluate SNF quality metrics via, again, the Medicare's Care Compare website to make informed decisions. As the healthcare landscape evolves, the balance between cost containment and patient care quality remains a pressing issue in SNF policy and operations. So it's determined by 3 things: health inspection rating, that's calculated from the points assigned to the results of nursing home surveys over the past 3 years, and complaint surveys. More recent surveys are weighed more heavily. The quality measures rating, calculated based on performance on 10 quality measures, separated into long stay and short stay. For long stay measures, that includes ADL decline, mobility decline, catheter use, high risk pressure ulcers, UTIs, physical restraints, moderate to severe pain, all things that we can help with. Staffing ratings are also a big part of this, calculated using the RN hours per resident per day, the total staffing hours. SNF must meet or exceed the 2025 CMS staffing study numbers. And why is Care Compare even important? Why did I take the time to mention it? For those of you that are on inpatient services, on consult services, for whatever reason, a patient who might benefit from inpatient rehab doesn't qualify, they probably will have to go to a SNF. That situation's pretty challenging for patients coming from out of town or who don't know what SNF to choose from. Families often have to rely on limited available information to make the decisions. So the Care Compare website is a valuable tool to share with them if the case managers haven't done so already. So this is actually Care Compare for a 1-star facility in Richmond. And then the next slide, I'll go to a 5-star facility. So I just want to highlight some of the things that makes this a 1-star facility. So the average number of residents per day in this facility is 203. The national average is 83, showing they have a higher number. Total number of nurses, staff hours per resident is 3 hours and 27 minutes. And the national average is 3 hours, 51 minutes, so they're below that. RN time is 31 minutes. The national average is 40 minutes. So again, they're below that. LPN time, 1 hour, 7 minutes. The national average is 52 minutes. They're over that. So does that kind of correlate with level of medical expertise, like the time provided? Nurse 8 hour, 1 hour, 49 minutes. National hours is 2 hour, 19 minutes. They're under. PT time is 7 minutes. The national average is 4 minutes. They're over for that. And this is a facility that many of us have rotated at. This is another facility. There you go. So the average number of residents here is 75. National average is 83. So they have less residents than average. Number of nursing staff per resident time is 4 hours and 6 minutes. The national average is 3 hours and 51 minutes. So again, what may make this 5-star facilities, they have a lot of nursing coverage and are able to provide that time for their patients. RN time 32 minutes, national average 40 minutes, so they're still under for that. LPN time 1 hour 10 minutes, national average 42, so they're over for that. So the biggest difference between the two comes down to nurse staffs per resident and simple oversight. Having more staff seeing the patient more often improves outcomes. Often when we're on call here, the biggest complaint, even in sheltering arms when we're on call, the biggest complaint when comparing day to overnight is the delay in response time for a patient requests. Like someone needs pain meds, they're missing an order, or someone just wants to talk to a provider. That's, not necessarily the page we're looking for at 2 a.m., but sometimes just having a provider there helps to answer basic questions. Now imagine a facility wait time where there's already massive shortages. You're not seeing your physician for weeks and weeks. That increases risk for issues and sets the stage for complications. So let's just look at some of the data. As of February 2025, the US Government of Accountability has not released a more recent report updating the data from 2021. In this data, they showed that in 2019, Medicare spent nearly $28 billion on care for 1.5 million beneficiaries in skilled nursing facilities. Approximately $5 billion of this was attributed to preventable critical events, including about 377,000 hospital readmissions within 30 days of SNF admission. The report highlights that while nearly all SNFs met the federal requirement of having an RN on site for 8 hours, again, that was the old requirement that just changed, only about half adjusted staffing based on resident acuity. Merely a quarter met the recommended nursing staffing thresholds to avoid quality issues, meaning that higher acuity residents who required more face-to-face care were not adequately served. Notably, RN staffing levels decreased by an average of 40% on the weekends, a factor not transparently reported on the Care Compare website, potentially hindering patients and families from making fully informed decisions. So what are some of the challenges, kind of plainly, that some of these SNFs face in providing a robust rehab treatment program is largely due to poor staffing, high staff turnover, which forces facilities to rely on expensive external staffing agencies to meet nursing and rehab therapy needs. This results, and often they have inconsistent primary care physician visits and oversight. The attending physician is not required to see them more than every 30 days. Often the physicians are internists or geriatricians, and the rest of the staff, especially nurses, may not have specialized rehab knowledge that's found in inpatient rehab facilities. This could often lead to a lack of cohesion between patient, family therapists, and the primary care physician and the nursing staff. The extra money brought in by PM&R, which comes at zero cost to the facility, can be used to fortify nursing ranks or upgrade the facility. The non-explicit benefits of having a PM&R physician could reduce complications and patient issues. Having additional medical eyes is invaluable. There's no explicit monetary benefit that you can say of just having a physician come see you and being able to catch stuff early. And I think that also plays out to, again, like just saying why we're also here on call. And the send outs that we were kind of just talking about earlier, like some of those send outs were valid, and those only happened because a physician was here on staff and seeing the patient. Otherwise, what it would essentially be like how it happens in private IRFs is they just send them out. Any issue to physician overnight that they obviously can't see the patient, they don't want to log into the chart, yep, just send them out. And that's kind of the report I've been getting. I've been interviewing around, and some of the attending physicians in private IRFs, that's what they do. So a patient survey conducted in 2017 at Barnabas University Medical Center. It's a private tertiary teaching hospital. They used a 6-item structured interview to assess Medicare's patients' perspective on the preventability of their readmissions from a SNF. The results showed that 34% of respondents rated their readmission as preventable. Of that 34%, 28% said that the readmission to the discharging was due to the discharging hospital, whereas 53% attributed the issue to the SNF. Contributing factors included 69% reported inadequate treatment, responsiveness, or monitoring, 20% cited improper medication management at the SNF, and 14% mentioned poor decision-making regarding transfer for readmission. So in a 2017 study by Rahman, the contribution of skilled nursing facilities to hospital readmission rate, it investigated the impact of skilled nursing facility on hospital readmission rates. They analyzed data to determine how the rehospitalization rate of SNF influences the likelihood of patients being readmitted to the hospital within 30 days of discharge. They found that the rehospitalization rate of SNF to which a patient is discharged has a more significant effect on the patient's risk of rehospitalization than the discharging hospital itself. Specifically, hospital readmission rates from SNFs varied by 5 percentage points between patients discharged to SNFs in the lowest and highest rehospitalization quartiles. The study concludes that identifying and referring patients to high-performing SNFs could be a powerful strategy for hospitals aiming to reduce hospital rehospitalizations. All of this points to a pretty clear picture. The current SNF landscape is marked by reduced staffing levels, their increasing risk for potential harm, poor outcomes, and increasing readmission rates. And that's where we come in. So let's discuss what a physiatrist can actually do in a SNF. So you can either be a physician of record, that's the admitting physician who has the primary medical responsibility for the resident. That isn't really that common right now. You could be the treating physician, someone who has personally valued the patient. This could be a consultant who sees the patient separately from the admitting physician. That's typically the role that more SNFs have switched to. You could be the facility medical director. The role may overlap with admitting physician or be separate. Medical director is responsible for leadership tasks like coordinating medical care, developing and evaluating care policies and procedures that reflect current standards of practice. Physiatrists and SNFs typically function in one of these three roles. So how can physiatrists help? Physiatrists could assist the SNF IDT team, which includes nurses, therapists, administrative staff. We could provide staff education, program development, implementation, administrative and regulatory issues, such as adapting to PDPM, helping be better at billing PDPM. They could help the SNF medical director with tasks that may be outside their comfort zone of other specialists. These tasks include ordering DMEs, which we're pretty comfortable with, documenting face-to-face encounters for home health care, advocating for patients in appeals that we do pretty often on our consult rotation here. So we're pretty well trained to do that. Determining the next level of care, maybe outpatient rehab, maybe they have to go to an IRF, serving as a secondary set of eyes for processes like determining cognitive status. Often physiatrists can participate in team meetings similar to those in inpatient rehab facilities to help reduce barrier to discharge. They could also review potential admissions, make sure that a SNF stay is appropriate and beneficial for the patient, provide education and counseling to patients and families. This is especially important because the frequency of physician visits can vary, and patients may not always have the opportunities to discuss their medical problems or prognosis in depth. A physiatrist, we're experienced in having these discussions, and we can reassure and provide clear planning regarding the patient's care, progress, prognosis. So one study looked at therapy intensity in SNF. As we know, one way that physiatrist involvement aids patients' outcome is reducing barriers, maximizing their ability to actively participate in therapy. While the impact of therapy outcomes is well documented in IRFs, it's less understood in a subacute setting. In 2018, a study by O'Brien and Zhang examined therapy intensity in SNF. It impacted discharge and outcomes for elderly Medicare patients, analyzed SNF data from about 311,000 beneficiaries across 3,000 SNFs. They showed that higher therapy intensity correlated with better discharge outcomes, increasing rates for returning home, fewer hospital readmissions, lower mortality. People who are receiving more than 60 minutes therapy per day were likely to be discharged home and had a shorter SNF stay. And this essentially states that more intensive rehab means better recovery and efficient care in SNFs. And by making sure their therapy is pain-free, they're able to do everything they need to do in therapy, we can maximize outcomes in SNF. So we are running out of time, so I'm going to kind of glaze over some of these. This is a case report that was done by RC that pretty much showed having a physiatrist in a facility helps things like ED visits, length of stay, readmissions. It was a case study primarily done in Chicago. So I'm going to skip some of the more marketing-like things I had, because what I had in mind when preparing this presentation is like, how can I market myself to a SNF in the same way that some of these companies are doing it? Because in order to really understand our value, we should know the value that we provide. So one of the biggest questions I do want to hit on is, they have geriatricians, right, in SNF facilities. Because of geriatricians training, they typically do consider the overall function of a patient in his or her environment as they age. They do ask rehab focused questions. They ask things like will he be able to perform his ADLs without help after discharge? Could they be more independent with therapy? What's the home environment? Essentially stating that they do ask a lot of things that we ask when we talk to a patient. Um, but thing is, like, do they want to, on top of all the medical things they have to deal with? Like, do they also want to deal with the rehab specific things? And talking with some primary care physicians, including my wife, who serves as one of the primary care physicians in the SNF facility, they don't have time. They simply don't have time to even meet the medical stuff that they need to. So let PM&R ask the rehab focused questions regarding functional status, developing effective treatment. Let us do the ICD-10 codes for the rehab stuff. Let us attend the rehab meetings on their patients. Let us do the things like length of stay, rehab issues. Let us update the patient and family about their rehab. Let us sign all the certifications to justify rehab services. Let us deal with the peer-to-peer appeals so the primary care physician in that facility could focus on the more nuanced medical issues and the things that they have to do. So there are some concerns about physiatrists getting involved in the SNF space. One concern is whether their role as a consulting physician adds enough benefit to justify the costs. As independent contractors, physiatrists bill Medicare directly, typically don't incur an actual cost to the facility. However, there have been concerns about physiatrists billing for seeing patients with limited or no real rehab needs and not providing care only where it is needed. As shown in the previous slides, hopefully as shown in the previous slide, there is a lack of research showing direct impact of physiatrists in the subacute space. Much of the justification benefit comes from analyzing the deficiencies in the SNF space and theorizing how we can help. Additionally, while it is possible to network with SNFs independently as a physiatrist, large for-profit corporations are establishing a stronger and stronger influence on contracting physiatrists in the SNF space. This raises the question as to whether the motive for physiatrist involvement is driven by profit versus actually addressing true patient need. However, hopefully my goal was to demonstrate that there is a patient need and to paint the picture that we are the missing piece of SNF care. Hopefully there's legislation in the future mandating physiatrists in the SNF, but given the size of our field, that may not be on the horizon. Conclusion, SNF function as a significant site, sorry, that's a typo, but SNF is a significant site for post-acute care in the US. Current landscape is fraught by understaffed facilities, preventable hospital readmissions, changes in payment policies for SNFs are incentivizing adherence to quality care. Physiatrists are aptly suited towards optimizing patient care, improving SNF outcomes through even though more research is needed to further substantiate this claim. Some of the questions I've kind of gotten over my past few rotations, does having more physiatrists and SNF hurt the field? I think in contrary, it does not. I think it increases our demand in the vast expanding post-acute care setting. It does decrease the supply of IPR docs, pain docs, but it just highlights the fact that we need more PM&R docs. It's rare to kind of see that PM&R doc of old who does IPR and then goes to SNF on the weekends. Can I do this on my own or independently? Yes, you can, but it's becoming increasingly difficult. Most SNF executives have working contract with some of these SNF companies already. So whenever they buy a new SNF, they essentially, the physiatrist group they're working with, they bring them on board. Maybe in a more rural setting, you could do it independently. But again, my only concern would be if when the SNF ownership changes, does change very often, you may get kicked out. So DOGE changes to government funding, future outlook to Medicare, bundled payments. Unfortunately, I don't have the answer for that. I don't think anyone does. That's kind of like I don't know if someone more experienced in the field on board may be able to answer that. But if Medicare gets hit, I think a lot of specialties and physicians are going to feel that pressure. What is the role of APPs or PAs in SNF facilities, whether independently or collaboratively with rehab? So there was a company that did try APP-led model, but it was not successful and profitable. They went under in about 4 years. This was attributed to maybe a lack of the rehab-focused training. Facilities were not really getting that benefit of having the medical expertise of an extra physician coverage. But most companies do use APPs and PAs in conjunction with the consulting physician and under their supervision, and that has worked really well. Facilities do want to see a physician if they're contracted with one at least once a week. And now I'll kind of open the floor to any questions anyone has. All right. Trevor, we're good. All right. Thank you.